Hello students, we'll discuss today an important topic. As for Oxy, it is also for undergraduate, postgraduate, surgeon, clinician, whoever it is, that is venous hypertension and varicose veins, a big topic in the exam for UGs and often for postgraduates also. It's a long case and many short notes will be asked, main question may be asked, clinical case will be kept, and very common a surgical entity which we come across in our day-to-day surgical practice in OPD, rather a morbid disease and a very distressing often and causes lots of sufferings, even though may not be a life-threatening disease as such. For students, it is important for Oxy, MCQs, and exam, theory, main question, short notes will be there, long case will be kept, ulcer, venous ulcer will be kept as a short case in the exam. So in all aspects of examination, it is very, very important. Learning as an important topic in the surgery, that is also, it is important. Of course, in detail, everything is there in my SRB's Manual of Surgery current edition with the MCQ booklet, 8th edition, currently running. And also my SRB Clinical Methods in Surgery, current edition with the detailed examination method properly with the photography as well as with the video, how to examine a patient and differential diagnosis with that. We can always go through that. And of course, my surgical YouTube, Surgical Insight website, live sessions already there, recorded one where student is presenting a venous disease, varicose vein, with the different faculties were there discussing and how case discussion for 1.5 hours. So how present a venous disease in the exam, what questions can be asked, how exactly, but everything is still there. So can make use of it. So without wasting much time, straight away I'll go and discuss briefly so that what you have to remember as a bird's eye view in relation to the venous hypertension and varicose vein, because its current CBSE syllabus, its coding is like that. So topic name is like that. So I put venous hypertension specific and varicose is a specific topic. So briefly I will discuss about surgical anatomy, which is very important, pathophysiology, and how to examine a patient in such way in varicose vein, how to manage such patient briefly so that you can have a clear idea, so that further details you can always go through my Manual of Surgery current edition. So what are varicose veins? So it's a dilated, tortuous, elongated. All these things are important. Dilated, tortuous, elongated, superficial veins with the reversal of blood flow due to valvular incompetence. Of course, in the lower limb, rarely it can occur in the upper limb also. There is a photo of upper limb varicose vein in my book. It's otherwise, by principle, it is considered in the legs because of the dependency. It is inelastic. There is how exactly it looks, pouched and friable. So elasticity is lost. So that's the most important. It bleeds a lot. Friable. It doesn't have normal structure. So this definition is very, very important. Remember, you should be able to define it, what is varicose vein when you are being asked. So 20, it's very common, 20% of general population all over the world. The different risk factors, obesity, long-standing occupation, and smoking may not be directly involved in male arterial disease, but still have the added effect on the perfusion of the limb. Pregnancy, ladies, and some collagen disease, malformations, all those things are the different risk factors. Few syndromes also associated with the varicose veins. Then vascular disease is also often associated with the varicose disease. A fistulas also associated with the varicose vein. Mainly occupation. It can be congenital or acquired. Congenital, where valvular infection is there, because after once blood is pumped into the legs, deoxygenated blood has to come to the heart back for circulation to maintain to reoxygenation. And there are valves actually, other than the cough pump. There are different methods how exactly from the periphery blood is returned back to the heart and lung. Mainly valves, long saphenous vein has got a 15 to 20 valves, short saphenous vein has got a 5 to 10 valves. So these valves push us in one direction, proximal, from the distal to proximal. So this incompetence occurs because of the different reason, maybe congenital valvular weakness or insufficiency, or acquired because of the recurrent thrombophlebitis or superficial thrombosis in thrombosis, in current terminology, or occupation, long-standing, more pressure, syndromes, vasculitis, and so on. So many conditions are there. You can read my book. So these risk factors lead into the varicose vein. Pregnancy is important, common hormones, estrogen and other hormones also important factor to cause varicose vein. Sometimes it is unilateral, sometimes it is bilateral, also in many patients. Sometimes it appears in one limb and eventually it occurs in the other limb also. So all these things you can see the tortuous, very exactly definition of exactly, see that all those definitions. You can see the long saphenous vein with all those changes in the skin, complications. A different way you can present with, that's how exactly it looks. So this is the anatomy. I'm not going to detail it. You can read this one. Tibial, popliteal, femoral veins, because they are veins of conduits, which drains into the iliac vein and AVC. Pumping means they are venous sinuses existing in the calf muscle. These are the classical veins actually. These are the venous sinuses. Like sinuses are like this, pouches, sinuses. That is in the calf. So that is pumping veins actually. They are better terms, musculovenous pumps are there are different. This is the clean cut veins like this. They are sinuses. So they are called as peripheral heart actually anatomically. And paired veins, I am not going to detail anatomy, anterior tibial, posterior tibial, peroneal, soleal, gastrostomy veins, eventually form the popliteal vein. Then subsartorial canal, it passes through as a femoral vein. And then profunda superficial vein like the profunda femoris joins like this. And later femoral vein continues external iliac vein, then internal iliac vein joins, and from the common iliac vein then becomes IVC and get into the heart, right side. So there is exactly basically anatomy of the deep venous system of exactly should know. And so this is what we are interested currently. Of course, deep veins also equally important, but visibility. And what this currently involves, varicose veins, this is what we are interested. Great saphenous with the longest vein in the body, also called as a long saphenous vein. And from the medial perspective, it runs upward. You got a 15-20 walls. Saphenous opening is 3.75 cm below and lateral to the pubic tubercle. Point is important. If this is like this is the vein like this. So this is the point where vein joins the femoral vein, superficial vein joins the femoral vein, goes like this. So there is a wall here actually. This is the vein continues here, femoral vein and external iliac vein. So this is the great saphenous vein. It joins like this. Saphenous vein, cribriform fascia is there. It opens. This is what in sonologically, Doppler wise, Doppler B mode duplex scanning Doppler. It looks like a saphenous eye or Egyptian eye. That's a typical terminology which is mentioned radiologically, sonologically as such. So short saphenous vein begins from the one is medial, another is lateral. It's got a variable length actually. It runs upward into the popliteal area. So from the lower margin of the popliteal fossa, it enters the popliteal vein variable distance, maybe in the middle, in the lower part, sometimes in the upper part, rather high. So variable, upper part is very variable level. It has got a 1 to 10 walls. This has got a 10 to, so that is a very important thing to maintain the upward direction of the flow of the blood, venous blood as such from the lower limb. And always it is upward, always from the superficial to deep. There is a deep vein is like this, superficial vein is like this. So there is a communicating vein, or there is perforating veins are there. This is called perforate the deep veins, deep fascia, perforating the deep fascia. And here also direction is from superficial to deep, never from deep to superficial. There's always a one wall usually in all perforator. It prevents the reversal of the flow from the deep venous system to the superficial vein. If there is a reversal of the flow by some reason, because of the incompetence of perforator in the perforator vein as such, then it will cause the varicose vein. So either incompetency of the great saphenous vein where it is joining the femoral vein, wall is incompetent, it can cause the long saphenous vein incompetence and varicose vein, or short saphenous vein into the popliteal vein. Sapheno-popliteal junction, it will cause varicose vein laterally of the short saphenous vein. Sapheno-femoral junction, SFJ it is called, 3.7 centimeter below and lateral to the pubic tubercle. It will cause the great saphenous vein, varicose vein. Perforator incompetence. There are many perforators. I'll just give the diagram. You can always go through my book. Above knee, below knee, above ankle. So many are there. Different names are there. Are important, especially when you write for MCQs or the clinical side. When you present a case, it will be asked. So important thing is it is a one valve. Direction is always from superficial to deep. If valve is incompetent, reversal occurs and varicose vein occurs below that point. So there is a point. So three types of varicose vein: great saphenous vein, long saphenous vein, perforator. There is some more terminology communicating, which I am going to discuss later. So these are the long saphenous vein, short saphenous vein, SFJ. This is SFJ, short form, saphenofemoral junction. This is SPJ, saphenopulpit. It's important. It's laterally and posterior. Medially, it is anterior and medially. See the direction. This is the long saphenous vein. This is the short saphenous vein here. So this diagram is very clear. What is small saphenous vein or short saphenous vein, great saphenous vein or long saphenous vein. So its meaning SFJ and SPJ is a popularly short form is called, and perforator means is called blowouts actually. When it's pathological, it is called as blowouts. Normally perforator means directed from superficial to deep. That point you have to remember. There is a one valve. If valve is incompetent, it becomes a blowout or perforator incompetency, otherwise called as. All these names I'm not going to different. Ankle perforator, Achillean perforator, calcaneal, lower leg 1, 2, 3 is there, gastrocnemius perforator, Boyd, mid thigh perforator, Hunter's perforator in the thigh. All this is named from below upward. You can always see that 1, 2, 3, 4, 5 anatomical location. Just remember this diagram in the exam when they ask all this diagram. You can once you remember this diagram, you'll be able to reproduce in the exam. And communicating means, sir, is different from one superficial vein to other vein. For example, from the short saphenous vein to long saphenous vein. In the saphenous fascia, skin, subcutaneous tissue, there is a different fascia, different textured area is there. Compartment, a saphenous compartment, it's called a saphenous fascia is there. From there, deep fascia is there. So in this saphenous compartment or in saphenous fascia or saphenous compartment, actually it is called as in the superficial fascia. As such, superficial to deep fascia. Long saphenous vein is there, short saphenous vein is there. Sometimes there is a communicating vein of variable length, often named, often unnamed, from between the short saphenous vein or long saphenous vein, or between the posterior arch vein to the long saphenous vein, or between posterior arch vein to the short saphenous vein. So, in the saphenous compartment or superficial venous system, veins may communicate from one to other. They are called as communicating veins. To say some terminology or meaning differences are there between perforator veins and communicating veins. Perforation is always which perforate the deep fascia, connects from the superficial vein to the deep venous system. Whereas there is a single wall, usually single wall, direction is only from superficial to the deep. Whereas communicating vein is from the one superficial vein to the other superficial vein, there is a connection. The different names are there, different types are there. I'm not going to detail it, that is there in my book. From the for example, short saphenous vein to the long saphenous, very common. Across the thigh and medially also from different veins. They are called as communicating veins. So terminology, meaning is most important. So all these things are the communicating vein, accessory, anterior accessory, great saphenous vein. I'm not going to detail. Giacomin is often asked as MCQ. Long intersaphenous communicating vein, it is called as Giacomin cruvilar vein. Long intersaphenous communicating vein. So all this may be asked as MCQ. That is exactly meaning actually. What is the meaning of communicating vein? So all these factors are important for venous return. Negative pressure in the thorax, peripheral pump. I already told what is peripheral heart, given the exact picture is it. Viscera intergo adjoining muscles and walls. These are the most important thing. Non-reflecting walls push up the blood from the periphery to the heart. So these are the factors which are responsible for the venous return, which you have to remember always. And venous hypertension. So normally there is a venous pressure, arterial pressure, capillary pressure. In the capillary, arteriolar pressure, venular pressure. In between there is a capillary. So arteriole, capillary, venule. There is a peripheral circulation, microcirculation complex. So pressure in these different areas are different. Venous pressure usually less. Arterial pressure is very high. You know that 80 to 100 to 120 millimeter of mercury. Venous pressure is usually 20 to 30 millimeter of mercury in the lower limb. And when this pressure increases, that is called as venous hypertension. It is ambulatory venous pressure. When patient walks or when patient stands, the pressure increases more than the normal. and usually often it goes up to the 80 millimeter mercury, very high venous hypertension, and it reduces the circulation pressure actually. So perfusion is decreased in the microcirculation, and so hypoxia occurs. So exchange will not occur. Oxygen exchange will not occur at the tissue level. That causes severe hypoxia, especially in the high pressure. Impact is around the ankle joint. One finger breadth, one hand breadth, not finger, sorry, one hand breadth around the ankle joint, and that area wherever the varicose vein, maybe great saphenous vein, SFJ incompetence or SPJ incompetence or perforated incompetence, wherever it is, that area burden occurs around the ankle joint, one hand breadth, circumferential area. That area is called the gaiter zone. All these problems, eczema, ulceration, bleeding, then lipodermatosclerosis, periostitis, thickening, everything occurs usually in this area. Sometimes little more proximal it may extend, but the burden is taken in this area. That's what's called a gaiter zone. Meaning of the gaiter, all of you know, it's a military people, at least in olden days, they used to cover this area with a brace. Olden days it was a metallic, and eventually it is a leather. So that area around the ankle, around hand, finger or hand breadth, where this is called gaiter, and this area is called clinically called a gaiter zone, where most hypertension, venous pressure, increased ambulatory venous pressure causes all problems, and high ambulatory venous hypertension occurs, and all complications of varicose vein occurs in this area, and that is the gaiter zone. That's why it is important, meaning of gaiter zone, why it happens, what is ambulatory venous hypertension, why it is significant. So I'm not going to detail it. Chronic venous insufficiency that causes all these things, all these complications. So there's the two theories are there. One is fibrin cuff theory, and another is white cell trapping theory. Because once hypoxia occurs and RBC get lysed, hematine is released, that causes a lot of irritation. So irritation causes fibrosis, and fibrosis causes thickening there. So it prevents the oxygenation, then hypoxia leads into the further problems, tissue damage, ulceration, and so that's a fibrin cuff theory. White cell trapping theory, leukocytes get trapped, and so it causes the problem in the exchange, macrophage problems, and eventually causes the problem. So this is, remember these two theories, at least names. In the exam they will ask, in the theory they will ask, in the Viva they will ask, in the Oxy they will ask, and when you present a long case they will ask what are the two theories, fibrin cuff theory and white cell trapping theory. Always you can go through my book for detail in a varicose venous disease, in detail with the diagram it is there, how exactly these two pathogenesis methods will develop complications of varicose vein as such. Remember these two things, fibrin cuff theory and white cell trapping theory. So you can read my book, Venous Disease, for detail about these things. So classification of varicose vein, I have told the diagram, I have told the definition, I have told the risk factor, I have told the different aspects of the venous hypertension, gaiter zone, and so on. There are different classifications I put in the tabular form, primary, secondary. Primary is maybe congenital valvular insufficiency or whatever it is. Secondary due to thrombophlebitis, long standing, then pregnancy, hormones, then injury, trauma, maybe obesity, so many things, syndromes. So this is symptomatic. Varicose veins are there, no symptoms. Symptoms are usually pain, calf pain, then distressing pain, then of course pigmentation, edema, ulceration. There is a complication with the symptoms. There are symptoms also. Symptomatic can be only pain or with the complications, ulceration, joint movement is difficult, and morbidity, gait is problem, walking is a pain is the most important thing. Once the ulcer forms and the thickening of the periosteum occurs, there is a lot of pain. This is the one which causes periostitis, chronic periostitis, recurrent periostitis around the ankle and lower leg, in the lower part of the tibia. That causes severe pain, and that is the distressing one many times these patients face. So thread veins, meaning MCQ question is 0.5 to 1 millimeter, they call thread veins. Little wider than that, it's called 1 to 3 millimeter. Varicose veins are more than 3 millimeter, and all these combinations of above in a single patient can occur. Great saphenous vein, small saphenous vein, perforators, combination of above. I already told the meaning of the great saphenous vein in the SFJ, short saphenous vein or small saphenous vein as the SPJ, and perforator, different levels, the superficial to the deep. I also told communicating means are different from the perforator, exact meaning I have already told. And clinical, this is the most important classification which you have to remember when you operate. You have to map the patient, you have to mark the patient. It's called CEAP, clinical, etiological, anatomical, and pathophysiological. This classification often asked as a short note, CEAP classification, exam they will ask, oxy they will ask, long case when you keep they will ask. So you have to remember detailed about 0 to 6. I'm not 7 are there, 0, 0, 1, 2, 3, 4, 5, 6, 6. 0, 1, 2, 3, 4, 5, 6. So from 0 to 6 it becomes 7. 7 grades are there. Go through my book. It is there. Subdivisions are there. Please go through that. So it will be asked. You should remember. So in a given patient, you should be able to write the CEAP classification and map this one. Usually clinical mapping, and of course after Doppler scanning also you have to map. Venous mapping it is. Venous hemodynamic mapping it is called as VHP. That the terminology which is used currently, venous hemodynamic mapping, you should be able to map it. And without complication, with the complication, I'm not going to discuss, you know all these things. Already told, lipodermatosclerosis is thickening and inverted beer bottle appearance, and talipes equinovarus, they can't walk because of fibrosis. They walk over the tip of the toe, like a horse. Talipes, equinus means horse, equinovarus. Talipes equinovarus, they walk like this. It's very currently not that common. Golden days, 30 years back when we were postgraduate, chronic varicose veins with a lot of complications, they used to come like that. Talipes equinovarus. Periostesis is very common, one of the main cause for the severe pain. Of course, ulceration also. Bleeding is quite common, definitely an indication for surgery. So remember the complications of varicose vein. Often after the short note, enumerate complications of varicose vein. You should be able to write all these things. Of course, read my manual, go through my SRB surgical website, YouTube channel, Insight, Surgical Insight. I can learn varicose vein in detail, all this about all these things. And all these things I am not going to reticular vein, meaning thread vein, already told, classical varicose vein, this is the lipodermatosclerosis. See that? Inverted beer bottle appearance, thick like this. Ankle is narrow, above it is divided like this. That is the typical of the inverted beer bottle appearance. So this is a saphenous varix. See that? Bulge in the junction of the saphenofemoral junction. Typical. This is the diagrammatic view of the same thing. And I'm not going to detail that. This is how exactly we tried the chief complaint. Night cramps are quite common in this patient. Complications which are this orderly, you have to mention the chief. All these are the things. Remember this table when you present a varicose vein. Orderly dilated vein, pain, and swelling, pigmentation, ulcer, and detail about everything you should write. Mass abdomen may be a cause for that. So it is etiological white also. So previous surgery is important. Previous surgery for varicose vein is important. Previous surgery in the abdomen is important. Trauma is important. Malignancy can cause different results. Smoking is important. Pregnancy, obstetric history, run in family. So family, 3-generation family is important. It may run in family. This is also important. Treatment history. Previously, patient might have some other surgeries, vascular surgeries, or many patient may be taking anticoagulant like small dose aspirin, clopidogrel, or warfarin anticoagulant. This is also important. Diabetes, hypertension, diseases. All this history you should be able to know. And laser examination, like any other long case, you have to write in detail without any short one. Never write a short one. And examine in standing. That is important. See, examine in standing this patient. That is important. Diseased limb first, then after the other limb. Compare always. Examine in standing. All round. Make the patient turn like this, round like this, round like this. Then examine the limb. And inspection, palpation, special tests. I'm not to detail it. Saphenous varix, skin changes, all these things. See, Maurice's cuff impulse is done in lying down position. This is important. Maurice's cuff impulse test is done in lying down position. In standing, it is a Cruvelier cuff impulse is done in the standing position. Ulcer, detail about swelling. Gaiters area, already told the meaning of that. It's an important MCQ question. Palpation is again warmness, tenderness, skin thickening, bone thickening. Run your finger over the periosteum, the leg, and calcaneum. If there is a bone thickening, that suggests periostitis. X-ray or MRI has to be taken, and difficult to treat such patient. And tests for DVT, all these things are there in my clinical book and manual. Modified Perthes test, modified Perthes, Homer's test, Moss test, Newhoff sign, Linton's test, swollen, painful, warm, indurated like in acute DVT. It's a feature of acute DVT, remember, acute DVT. So this is important because the DVT is a contraindication for direct surgery for the varicose vein. That's important. That point you have to remember. So whether a patient is having DVT or not makes a lot of difference in these patients. It causes added problem and intervention also difficult in this patient. These tests are important. Brody tunnel test 1 and 2. 1 is for great saphenous vein. 2 is for perforator. Apply a tourniquet after elevation and milking the limb, emptying the vein. Then apply a tourniquet around the saphenofemoral junction and 3.75 or 4 centimeter below and lateral to the priviotubercle. Then ask the patient to stand, release the tourniquet. If there is a reversal of flow from above downward, rapid filling from above downward, then it is called SFJ incompetence. And again empty it, apply a tourniquet. Don't release it if there is a rapid filling from below upward within a minute or two. That means there is a perforated incompetence. If there is perforated incompetence, then negative 3 or more tourniquet tests you have to do. Empty the vein, apply tourniquet from below SFJ and above knee, below knee and around the ankle, about the ankle. Then ask the patient to stand, observe in between, then release a tourniquet from below upward, not from above downward. Then look for which perforated incompetence. It's important to find out whether perforated incompetence is present or not, along with the, if at all, along with the major vein like GSV and SSV incompetence. Standing is important. And 3 tourniquet test. 3 tourniquet test. A tourniquet test for SSV is important. Many times you write short saphenous vein incompetence without doing a tourniquet test. Similarly, like what you are doing tourniquet test for great saphenous vein, you have to do a tourniquet test for short saphenous vein if you are writing a short saphenous vein incompetence. So examine the laterally from behind also. If there is a dilated vein laterally and behind, then empty the vein, apply a tourniquet just below the popliteal fossa and ask the patient to stand, release the tourniquet. Rapid filling from above downward suggests that is short saphenous vein incompetence. Without doing that test, we can't write that is a short saphenous vein by convention, remember. All these things are the different tests for the SFJ and perforator. Fagan's test is important, called blowout. I said perforated incompetence, otherwise clinically called as blowout. Fagan's test is the most important test. Elevate the limb and run your finger along the vein. You can feel the depression, crescent-like depression. Then mark it out, and after that, ask the patient to stand and again run your finger. You see the blowout. First you will stand the patient also, then run your finger, blow out, mark it, and elevate, then run your finger. You can feel the crescent-like depression. That is called Fagan's test, very important. And Cuvier sign, Morris says, this is in the lying down position, MCQ question. This is the standing, don't get confused. Morris's cup impulse is in lying down position. And measurement of limb is important, marking the perforator is important, as already told. Auscultation, SFJ and SPJ for AV fistula. This is for AV fistula, Brui for AV fistula, venous for venous component. Peripheral pulse is important. If there is a venous disease, varicose vein, with the peripheral vascular disease, arterial disease also, there is a club defect, venous disease and arterial disease that cause added insult to the limb, and limb will be really problematic, will be difficult to do surgery. Sometimes they will go for other major complications. Inguinal lymph node, especially there is an infection, inflammation, ulcer. Inguinal lymph node may get repeated because of the repeated inflammation, especially vertical group of lymph nodes. You have to always examine inguinal lymph nodes. Of course, abdomen, chest, cardiovascular system, it should be spine and other systems also should be examined. Joint is most important thing, especially ankle joint and subtalar joint. Ankle joint causes dorsiflexion and plantar flexion, not inversion and eversion. Remember, you get confused actually. Dorsiflexion, plantar flexion. Dorsiflexion is around 45 to 50 degree. Plantar flexion is around 45 to 50 degree. Dorsiflexion is around 40 to 45 degree. And eversion is the subtalar joint. Inversion and eversion. Inversion is around 20 to 30 degree. Eversion is around 15 to 20 degree. So inversion, remember inversion, eversion in the subtalar joint. Dorsiflexion, plantar flexion in the ankle joint. Don't get confused. And how to examine, you can always go through my clinical method book, where video is clearly shown how to examine the patient. So go through my clinical method book, method book, how to check the joint in a varicose vein. This is important. Remember ankle, dorsiflexion, plantar flexion, subtalar joint, inversion, eversion. Don't get confused. Opposite limb is important. Gait is, you have to always make the patient walk. Abdomen examination, other system examination. All these things are important in this one. Complete diagnosis you have to give. Venous ulcer, right leg, middle aspect, right ankle due to incompetence of great stubbornness vein, below knee perforator. No evidence of DVT clinically present. Clinically, of course. It's a clinical diagnosis. Which side, everything. Give a complete diagnosis always. And this is exactly look for. Always in standing. Both all side you have to check. Tourniquet, this is exactly play the tourniquet. This is a 3 tourniquet or more tourniquet. Multiple tourniquet test. There is the marking of the perforator. First in standing actually, below what you mark. Then in elevation you mark the Fagan's test actually. This is the lipodermatosclerosis. This is the gaiters zone area. And this is short test. This is a cruel. In standing position, cuff impulse is Cruvellier sign. Lying down position, it is a Morrissey's cuff impulse. Bone thickening in a venous ulcer, you have to check. This is the modified Perthes test for DVT. All tests you will empty the vein. Here, no, do not empty the vein. Do not empty the vein in modified Perthes test. All other tests you will empty the vein. Modified Perthes, do not empty the vein. Apply tourniquet test FJ. Ask the patient a brisk walk. Patient will develop. Most important thing is patient will develop bursting pain as if deep fascias get torn off. And then of course, more prominent veins will be visible. Superficial veins will be visible. That is a secondary finding which we look for. Second finding which we look for. Main thing is bursting pain. The patient will not refuse to walk. Then you release the tourniquet, blood will be drained because deep veins is blocked because of the DVT. So all these circulation blood, venous blood to drain through the superficial venous system. Of course, they are incompetent. That's a different thing. And through the femoral vein and like that. If you block that one also, no way venous blood can drain across into the heart. So this brisk walk really pushes and pressure increases, causes severe pain. So it is done in standing, done without emptying. No emptying, always standing. Modified Perthes. No emptying, no emptying, no emptying in the modified Perthes test. Most important thing you have to remember. So venous ulcer like that, ulcer examination is important. These are the reticular veins, different pie also examine all around is important. And venous Doppler, full name you have to tell. Venous Doppler, what investigation you will do? Venous Doppler with the B mode. B means bright mode, brightness mode. Brightness mode, motion mode is there. 2 modes are there. Motion mode is used mainly for echocardiography. All other tests, Doppler scans are usually B mode. That is brightness mode Doppler scan. Saphenous eye or Egyptian eye, blood tests are important like ultrasound abdomen for compression, ECG, echo, X-ray of the part for periostitis. We can do MRI also currently to see the bone thickening and soft tissue inflammation. Ulcer discharge ready, wedge biopsy from the edge. Especially if you think chronic long-standing venous ulcer can cause marginal ulcer, squamous cell carcinoma, well-defined squamous cell carcinoma without lymph node spread, without vascular invasion. So it's locally malignant disease, marginal ulcer. It's a well-defined squamous cell carcinoma. Long-standing, unstable scar of long duration. The word is important. When the scars are unstable in a chronic venous ulcer of long duration, that may turn into squamous cell carcinoma. But because of the scar, there are no lymphatics, no vascular system, not much vessels also. So no vascular invasion, no lymphatic invasion. So lymph nodes will not get involved. Lymph node may get enlarged because of the infection, not by the tumor. So special tests are important, remember. But they are not commonly done. Just remember the names. Nobody will ask. But if you want to detail, you can go through my clinical book. It is there in detail. And also in my manual it is there. Otherwise, it is not usually done. Only these things are commonly done. That is more than sufficient. And this is exactly Doppler should be done in standing position. Radiologist doing the Doppler here. Mapping is important with the Doppler. And this is the Egyptian eye or saphenous eye. And treatment is conservative treatment, mainly limb elevation, electric crepe bandage, sometimes pneumatic bandage, unna boards, different layers boards, different layered dressing that is called. You can read in my book, it is there, manual. Unna boards meaning what are the layers. You can read it often as a small short note, one sentence short note that you can read. Pneumatic compression also very helpful. That is the most important thing. Elevation, compression bandage. Elevation, compression bandage. And again, from the toes you have to apply, not from the ankle. If you apply from the ankle, edema of the foot will occur. Usually, above proximal to the knee you have to apply. Many times patients will put only short segment. It is not sufficient. That is useless. From the toes up to the proximal, just in the up to the thigh, you have to apply this compression, crepe bandage or compression stockings. Better stockings actually. Stockings of different size will come and better. Many prefer to crepe band but get loosened easily. But application is easier. Stockings to apply fast is difficult, but stockings are better than crepe bandage. Stockings are better. And drugs used for calcium domoxylate and diosmin is the drugs which is commonly used to reduce the venous tone around the ankle, so that once venous tone is reduced, so problems will reduce and perfusion will increase. So that's how exactly these drugs will help. They reduce the venous tone, which is one of the venous, it controls the venous hypertension actually. That's why it reduces the problem. So treatment, surgical treatment is generally Berg operation. That's juxtafemoral flush ligation of the great saphenous vein after ligating named perforator and unnamed perforators. That is the full terminology. Femoral vein is like that, and saphenous vein is like this. Just toward the wall of the femoral vein, but important, don't injure the femoral vein. It will cause problem. Here you will double ligate saphenous vein, and before that, ligate named perforator, superficial epigastric, lateral circumflex, medius, and superficial external potential. And unnamed veins are the ligated. Then ligate the SFJ in the wall of the femoral vein, juxtafemoral, adjacent to the femoral. That word is important. Then of course, a passive stripper, Meyer stripper, MYER, and Codman stripper. Two types are there: extraluminal, intraluminal. Meyer is extraluminal, Codman is intraluminal, and two names you have to remember. And pass the stripper and remove the vein. Stripper you can pass above the ankle, not up to the ankle, 5 centimeter above the ankle, because around the ankle, if you do that, you may injure saphenous nerve, which accompanies the great saphenous vein. If you injure that, it may cause the saphenous neuralgia. So usually up to the middle of the leg, you pass the stripper and strip the vein. Otherwise, you do a perforator ligation. And other things are the laser. Currently, it's a very popular. It's a laser, endovenous laser ablation. Very good actually. Usually diode laser. What laser is used to ask the MCQ question? Viva they will ask. Diode laser 1470 is the nano frequency. So wavelength you have to remember 1470 wavelength, diode laser, and EVLA, endovenous laser ablation, and RFA also there, radio frequency ablation also there, and laser causes around 800-degree temperature at the tip, so it completely seals the vein, whereas RFA causes around 80 to 190-degree temperature. Temperature is less in a radio frequency ablation. Effect is same, but laser is said to be better. Individual surgeons, individual studies, different versions. So there are two types of ablative procedures of new one. RFA is a radio frequency ablation. This causes 80 to 90-degree temperature at the tip, whereas the laser is a diode laser 1470 wavelength. It causes 1000-degree, 800-degree temperature, 800 centigrade at the tip. So you have to tumescent solution you have to apply, saline with local and sodium bicarbonate. You apply, you have to keep on injecting when you fire the laser, so that it cause a burn injury to the skin, so that saline will be there for prevent the burn injury. It is called a tumescent fluid, TUMESCENT fluid. Often you will inject the lignocaine also, then become tumescent anesthesia. Sodium bicarbonate, lignocaine, then saline. You inject, keep on injecting wherever you fire, keep on injecting. Without that, because it gives a tamponade also, it will dissipate temperature, high temperature also, it will prevent the burn injury of the skin because of the high temperature at the tip. So the three reasons why you have to use tumescent solution to have to inject while firing the laser or radio frequency, mainly laser, and also for radio frequency because of the high temperature. Sclerotherapy is a very popular foam sclerotherapy, 5 ml layer, 0.5 ml to 1 ml fluorescent. Mix it in a proper specialized syringes, syringe through two-way stop clock and 2 syringes. Then make a 6 ml foam, inject into the vein different places. Usually around 6 ml total of the fluorescent you can inject at time. Different points you inject so that sclerosis of the vein. Often if you retrovisit, it may cause the ulceration, irritation, pain, very irritant. Very rarely it causes systemic circulation, it enters and causes a problem, very uncommon. Do can occur theoretically, but uncommon practically, but do can occur. Often it may proceed to DVT, Again, very uncommon complication. And irritation is common, pain is common, extravasation, ulceration can occur. There is a common complication of foam sclerotherapy. And sodium sulfate is a common thing. And ulcer treatment, venous ulcer treatment, Bisagard method. Look at the spelling, BISGAARD, BISGAARD. Elevation, passive exercise, active exercise. This is this one, of course. Other than that, venous ulcer, clean the dressing, put the limb elevation, first discharge for culture. If there is infection, start antibiotic. Then, of course, massaging and compression bandage. Until ulcer granulates well, then you can put a grafting. Along with that, treat the cause, of course. Always confirm there is no deep vein thrombosis, DVT. All these things important. DVT should be ruled out or confirmed, because DVT is a dreaded thing. Even chronic DVT will prevent the ulcer or complication to get rid of. Very difficult to get rid of. Most important thing is elevation, rest, compression. These are the three things most important to make a ulcer to heal, to reduce the, to control the complication, to reverse the complication properly. So this is the three things: elevation, rest, compression, bandage. Three things are most important. Bisagard method is mainly for ulcer healing. Usol is commonly used. Usol bath you will give sometimes. Edinburgh University solution of lime contains boric acid, calcium hydroxide, and bleaching powder. So the three components. So it is a non-irritant clear fluid, but it's put in a blue tinged bottle so that prevents the oxidation probably. And you can put into the warm water and ask the patient to put the leg into that. It's called Usol bath. Otherwise, you can do the Usol dressing because it's a de-sloughing agent, non-irritant de-sloughing agent. Full form member, Edinburgh University solution contains boric acid, calcium hydroxide, bleaching powder. And so this is the Bisagard method, often asked in MCQ, Viva, clinical side, short, long case. Will venous ulcer is a short note. How treatment of venous ulcer is a short note. So you should remember that. So it's the stripping method. Myers stripper it is. It's Myers stripper. See that how exactly it looks like that. So stripping from below upward. Now take care of the saphenous nerve. Up to here you can strip. Don't come up to the leg. This is what theoretically book says. And this is the perforate ligation. This is the emulsion. It's very commonly done procedure. It's a beautiful procedure, simple and easier. And the perforate, if you have to recovery is good. This is the laser. It's a laser fiber, laser power setup. The laser, how glowing is very important. Glowing, you can see that. You have to always mark. You have to map the vein before using all these advanced techniques. This is called mapping before surgery, using a Doppler. That's important. This is the laser. Again, I will repeat: 1470 nanomillimeter wavelength, around 800 degree temperature, centigrade at the tip. Laser ablation is, and tumescent solution should be injected to prevent heat dissipate, or to dissipate heat, to prevent burn, and to create tamponade. And foam sclerotherapy, already told, this is the commonest one which is used often. Many places they use polidocanol also. This is of exactly, this is a stopcock here, stopcock, and this is of exactly create a foam, 0.5 ml or 1 ml plus 5 ml air, mix and inject. These are the complications. I am not going to discuss. I already discussed. This is often asked as a short note, very common. Enumerate complications of varicose vein and all those marginal ulcer. I already told what exactly it means. Unstable scar of long duration. And now currently marginal ulcer concepts have changed. Please go through my book. Detailed it is given very detailed in the current new edition, 8th edition. Concepts have changed to different version. And this is the different varicose vein ulcers. You can see that. And remember, it's a long case, short case, main question, MCQs. Always examine standing. Different tests are important, clinical test. Brody-Tellenberg test, 3 tourniquet test, Fagan's test, Maurice's cuff impulse, short test. Ask the patient to stand. Tap lower part. In the upper part, you can feel the impulse. Because walls from the site of the top into the site of feeling will be incorporated. It's a continuous, word is continuous column of blood, so that you can feel it. That is short test. Maurice's cuff impulse in lying down position. Crewless cuff impulse is in a standing position. Fagan test for the perforator definition, defining it. The thickening of the bone is important. Ankle joint movement is important. Peripheral pulse should be examined. Inguinal lymph node should be examined. And 3 tourniquet test, all those tests are important. Modified perthes, never empty the vein. Apply a tourniquet SFJ and ask the patient to have brisk walk. Bursting pain is the most important thing you look for. Of course, after that, dilated vein. More prominent vein which is exiting. Never empty the vein. All other tests are done after emptying the vein. CEPA classification is important, already given. B mode Doppler scan. What investigation you will do? Venous Doppler with the B mode Doppler scan, where you see, look for the DVT, perforator level, long saphenous vein, short saphenous vein, communicate, complete venous anatomy. That is called venous hemodynamic mapping. That is what you will do. Of course, surgical interventions are important. Different treatment strategies, old and current. Cosmos is also important. Complications also should be avoided and should be treated. Recurrence is common. We have to always explain the patient. Recurrence is common. After surgery, after therapy also, they have to elevate the limb. They have to use the compression band in day to day their work timing. This is the point which you remember. So go through my manual of surgery and clinical method for detail about the examination and different concepts and treatment strategies, investigation, everything, including DVT, different anticoagulants, heparin, low molecular weight heparin, pulmonary embolism briefly, and varicose vein detail, pictures, diagram, CA classification, fibrin cup theory, and weight cell trapping theory. Everything is there in my book. You can go through that. That is so exactly. Students, again, I request you to subscribe my YouTube channel, SRB Surgical Insight. Share with your friends, and it's free. And we got a live session at regular interval where students will present a case, long case, and many faculties other than me, senior faculty will discuss. So we'll get certificate also who we are presenting, and in detail discussion, presentation, clinical discussion, and investigation treatment strategy also will be discussed. And also day to day MCQs are there. Lot of already around 450 video lectures are there. Operative procedure, suturing technique, complications, clinical cases. Please go through my website, Learn Surgery Daily, which is free, and you can learn interestingly also. And go through my manual, SRB manual surgery and SRB clinical method surgery. If you go through it properly, everything you can learn surgery properly. In the current edition, 8th edition manual, there is a MCQ in a separate booklet. It will be very useful to go through that, so that you will learn surgery easily. You can face any exam, including an interest exam also, because most of the MCQs, whatever there, it is there in my book. So they can you can learn surgery in a proper way. So again, go through and subscribe my request. Again, subscribe my YouTube channel. Go through my YouTube channel, Learn Surgery in easier way, and have my manual of surgery current edition, and also my clinical methods of surgery current edition. And also give any comments, your opinions also about all these things. So students, I hope you understood this lecture about venous hypertension very well. Thank you so much.